Well, good morning, everyone, and welcome to our 2021 Ovarian Cancer Australia Symposium. My name's Jane Hill, and I'm the CEO of Ovarian Cancer Australia. Firstly, on behalf of all the women diagnosed with ovarian cancer, I'd like to say a big thank you to all of you, whether you're a researcher, whether you work in the direct care of women with ovarian cancer, if you're a policymaker in industry. I'd like to thank you for the work that you're contributing towards overcoming ovarian cancer. I'd also like to acknowledge the traditional custodians of the many lands that we're situated on today. I'm on the Wurundjeri lands, and I pay my respects to their elders past, present, and emerging. I'm so excited this morning to be part of this important symposium. I hope you're finding the sessions thought-provoking and inspiring as we hear presentations from some of the most august international and national experts discussing some of the latest developments and advances in ovarian cancer research and treatment. I'd like to thank all our incredible guest speakers for giving their time to be with us today. And also thank you to our advisory group who were instrumental in crafting the scientific program. Professor David Botel, Professor Anna DeFazio, Dr. Gail Gassard, and Dr. Tarek Menyawi. We'll be sending out some gifts in appreciation of their time and support. Ovarian Cancer Australia, we're a national organisation established 20 years ago to provide support to women and their families affected by ovarian cancer. I'm confident today that the generous sharing of ideas and expertise made possible by holding events such as these is critical to achieving our vision to save lives and ensure that no woman with ovarian cancer walks alone. Ovarian Cancer Australia offers a range of support services for women and families, including a support line, a telephone and face-to-face support groups, consumer forums, webinars, and an online forum. Additionally, our Teal support program is a free national telehealth outreach program tailored to each individual, where specialist ovarian cancer nurses, a psychosocial counsellor, and social workers support women throughout their diagnosis, treatment, and beyond. OCA's excellence in service provision was recognised last year in the Nursing and Midwifery Awards when OCA was named the Organisation of the Year. Our resources, such as our Resilience Kit, provide women with information on diagnosis, treatment, and well-being, and they're all free of charge and can be ordered through the OCA website. We're also active in advocacy, and last year with our partners ANZGOG and ASGO, we developed the National Action Plan for Ovarian Cancer. If you haven't had an opportunity to view it, it can be seen on our website. I'd like to make a special thank you to AstraZeneca for providing the funding to enable Ovarian Cancer Australia to hold this symposium. And also a special thank you must go to Ovarian Cancer Australia's Dr. Vanessa Alford and Cyril Dixon and all the team, the Ovarian Cancer Australia support team, for their hard work and dedication in bringing this event to life. So without further delay, let's begin our fourth and final session of the 2021 Ovarian Cancer Symposium. I'd like to invite the chair of this session, Elaine Sanich, to the microphone. Thank you.
Good morning, and thank you, everyone. My name is Elaine Sanic. I'm a lab head at St. Vincent Institute of Medical Research, and I'm delighted to chair today's session. I would also like to acknowledging elders, past, present, and emerging of all the land we work and live on, and their ancestral spirits with gratitude and respect. Today, we have three world-renowned researchers and scientists in ovarian cancer in this session on PARP inhibitors. I'm looking forward to great discussions. So please enter your questions in the Q&A tab on the top right-hand corner. And you can post your questions there, and you can also vote on questions using the arrow next to the question. And without further ado, I would like to introduce our first speaker, Dr. Kathleen Moore. Dr. Kathleen Moore is a Virginia Curley Cade Endowed Chair in Cancer Development and Associate Professor of Gynecologic Oncology in the Department of Obstetrics and Gynecology at the University of Oklahoma Health Sciences Center. She currently serves as the Associate Director of Clinical Research and the Director of the Oklahoma TSET Phase 1 program at the Stevenson Cancer Center. Her primary areas of interest are in new drug development and Phase 1 clinical trials, and the presentation title is Changes and Challenges in the Treatment Paradigm for Frontline Ovarian Cancer. Over to you, Kathleen.
Well, thank you. Thank you so much for the invitation to speak today. I am in awe of my speaker group. Doctors Claire and DeAndrea are kind of two of my heroes in the field, and Pol Theta is target. So I can't wait to hear Dr. Andrea talk about that. But I'm going to take us through just sort of the frontline changes in ovarian cancer. And I did incorporate some of the data from ASCO. So we'll have kind of hopefully a most up-to-date presentation. So I'm going to share my screen with you. Share. And just make sure you can see my slides. And all right, please let me know if you can't. Hopefully someone will text me if you can't see them. So what I'm going to do is just start this presentation by just framing it with a case. And I won't talk about this case the whole time, but just we can start the discussion with this case. And she should be very familiar to you. She's 65 years old. She presented in the usual fashion. She's got 3 months of abdominal bloating, a little bit of shortness of breath, presents to her primary care provider with a distended abdomen and a palpable mass on exam with some nodularity. She's sent for a CA 125 and it's markedly elevated, almost 5,000. And her CT scan looks very characteristic for ovarian cancer with ascites and large adnexal masses. But other than this, she's a very healthy person, only has hypertension as a comorbidity. She is a real patient. She was, from a few years ago, she was kind of, we called a scope and score, had a laparoscopy, was felt to be resectable, and really underwent a very aggressive attempt at surgical cytoreduction, but unfortunately was at the end found to have some porta nodes that were unresectable, and so was left with residual disease. She recovered very well from surgery, went on to receive paclitaxel and carboplatin every 21 days, and during this was sent for genetic counseling and genetic testing, and was found to have a germline BRCA2 mutation. And so the question then, and this was in 2017, is sort of what's next for this patient who had a complete response, her node went away, all disease resolved to how we individualize frontline therapy for women with ovarian cancer. These are all the things that you think about and I think about. And it's just a myriad of things. It's not just surgery and paclitaxel and carboplatin for everyone. We think about the timing of surgery. We think about the likelihood of getting someone to no gross residual, the comorbidities of our patient, her pathology. Is this a clear cell or is this a high-grade serous? What stage is she? And more recently, really in the past few years, is the genomic profile inclusive of germline or somatic BRCA and other high penetrance genes. More recently, homologous recombination deficiency, and you're going to hear about that at length from an essential, in my opinion, to determining the selection of treatment and really the selection of maintenance therapy for women in the front line. And so let's just sort of set expectations historically. What can we expect with paclitaxel and carboplatin alone? So what I'm showing you here is ICON 8, not so much to talk about ICON 8, other than to say that ICON 8 is probably the last study that we'll ever run in high-grade epithelial ovarian cancer with no biologic and no maintenance. So ICON 8 was purely a study of paclitaxel and carboplatin given in different ways with no maintenance. And it's the most recent study to be completed. And so I'm showing it to you because it kind of represents modern era supportive care. And despite that, it looks exactly the same as every other progression-free survival curve for the last 2 decades. But there's 2 things I want to point out, and hopefully you can see my cursor. If you look in this upper left-hand progression-free survival curve, you'll see this shoulder. And this shoulder represents the 20% of women who either progress on or within 6 months of completion of frontline chemotherapy. These women have primary platinum-resistant tumors, and despite a ton of effort, we have not been able to eliminate that shoulder, and falling in that category, unfortunately, represents a very poor prognostic group of tumors that we need to solve. And the other thing to point out is if you look again, hopefully you can see my cursor, but by this 3-year mark, about 75 to 80% of women who present with high-grade epithelial ovarian cancer will have recurred or progressed. Now, fortunately, we have many things for treatment, for many lines of therapy, and we are, again, fortunate to be living in a time where, in the developed world at least, there's a higher prevalence of women living with ovarian cancer than we ever have had in the past, despite no difference in incidence and mortality. And why is that? Well, because we have better supportive care and also better sequencing and more active agents that allow us to incrementally push out the progression-free survival over time. So we have more women surviving, but surviving with their tumor, not long-term disease-free survival. And so that's the problem. So if we are going to impact favorably the fraction of women who are in this cure group, it's got to be in the front line. And so that's what we're trying to do. And so our first big push towards this was the addition
with and to follow frontline chemotherapy. These are very old studies now, almost 20 years ago, or say 2011, 10 years ago, a decade ago. But both were positive for progression-free survival.
Neither were positive for overall survival. And so to use a baseball analogy, we would call this a base hit. So it's important. It does push the progression-free survival out approximately 4 to 6 months, depending on how you're looking at it. And that's an important endpoint. And so these are, in some parts of the world, it is the standard of care to use bevacizumab in the front line. In other parts of the world, it's a standard of care. It's an option. But it certainly didn't impact cure. And as we heard at ASCO this year, adding an additional 15 months of bevacizumab to the 15 months prescribed in these studies did not change that. And so the standard remains 15 months of bevacizumab. And that's what I was just showing you here. I forgot that I put it in here. So the question when we finished ICON 7 and GOG 218 was whether or not the absence of benefit in overall survival was related to the fact that we stopped the bevacizumab too early. And why did we think this? Well, we thought this because if you look at all of these studies that were done with bevacizumab in the front line and in the second line, we call this the banana sign. When you stop the bevacizumab, the curves come back together and they make a banana. And so this brought up the hypothesis that maybe if you didn't stop the bevacizumab, the curves would remain apart and you would see an improvement in overall survival. And so this was studied in the AGO-OVAR 17 boost study, which was presented at ASCO. And honestly, we were all really excited about this. It had 84 months of follow-up. So we all thought that this was going to be positive. And it asked the simple question, following those 2 frontline studies in 2011, should we keep bevacizumab going for 30 months instead of 15 months? No new safety signals were seen with increased use of bevacizumab, so it was certainly safe and feasible to do this. And again, no new safety issues were seen, but it didn't help. Not one bit. There was absolutely no difference in progression-free survival if you kept the bevacizumab going. It didn't matter what risk group you put it in. If you looked at women that had sort of lower risk ovarian cancer, stage 2B and 3C with no residual tumor, no benefit. If you looked at the high risk patients, which if you look at subset analysis from ICON 7, this is the group that had a signal that their overall survival was better, no evidence of. So for in the US, this was there were a lot of early adopters of Bev Forever. And they need to stop because there's no benefit and it didn't improve overall survival. So back to the drawing board. Fortunately, though, we had already been studying PARP inhibitors, which really did, I think, change the landscape. And so when you look at this timeline since 2014, which is not that long ago, every new approval that we have seen by the EMA or FDA has been a PARP inhibitor, except for the 2 approvals for bevacizumab that I just told you about. Everything else is a PARP inhibitor, and why is this? Because it works. And you've probably heard about that and you'll continue to hear about it in this session. And it all started in the recurrent setting with Bella Kaufman's paper and then in the platinum sensitive recurrent setting. But it really came to kind of a big celebration with SOLO-1, which I had the great privilege of leading with Paul DiSilvestro. So SOLO-1 was designed, I'll remind you, in 2012. So even though we reported it just a few years ago, it's kind of an old study. We probably would have designed it a little differently had we designed it now. But be that as it may, this was a study that enrolled women with advanced ovarian cancer, stage 3 or 4. They had to have an attempt at a surgery. They had to be in response, either complete or partial, to their platinum-based therapy, and they had to have a BRCA-associated cancer, and in this case, it was almost entirely germline BRCA. At the conclusion of their therapy, they were randomized to either Olaparib 300 milligrams twice a day or placebo in a 2-to-1 randomization, and this was continued until toxicity or progression, but if neither of those things occurred, at the 2-year mark, the assigned therapy was discontinued. And the primary endpoint was investigator-assessed progression-free survival. And so I'm showing you the the updated PFS that Susanna Banerjee presented at ESMO just last year, because we have now 60 months of follow-up. And I like this build because it kind of shows you the impact of the first 2 years of Olaparib, and you can see that here. Now remember, this group of women, and I'll show you a few slides, were predominantly those who received primary cytoreduction, mostly stage 3. So in the kind of risk stratification for clinical risk prognostic factors, they were on the lower end. And they all had BRCA. So you would expect, there was this mythology around these women that they were all cured with chemo alone and we were over-treating them. And you can clearly see from this that is absolutely false. In the blue, the light blue, which I hope you can see, these are the women randomized to placebo. And even though they all had BRCA-associated cancers and they were relatively good clinical prognostic factors, they recurred very quickly. And you still see that 20% that had primary platinum-resistant disease, which quite frankly, I was very surprised to see, because we'd never studied this group prospectively before in the frontline. This was the first study. Now, if you look at the women who were randomized to Olaparib, there's only 4% of women who progressed within the first 6 months following chemotherapy. And you can see at 2 years, when the treatment is discontinued, we have 74% versus 35% of women on Olaparib versus placebo who are disease-free. Now, is there a banana curve? You stop the treatment, do the curves come back together? And the answer is no. And actually, the slope of these curves is very similar. So the event rates after 2 years, kind of between 2 and 3 years, the event rates are almost identical here between the Olaparib and the placebo arms, both groups, of course, not on therapy. And at 5 years, we have almost 50% of women with without evidence of recurrence, and 21% who got placebo only without evidence of recurrence. So you can see the medians here and the hazard ratio with a 70% reduction in the risk of progression or death. So unprecedented improvement, and of course led to global approvals that were very exciting for our patients. Now, I mentioned this sort of prognostic clinical prognostic features of women who had higher or less high risk. I don't think any woman with advanced ovarian cancer has low risk disease, but we did separate out, this was in an exploratory analysis to look at women with higher risk clinical factors like stage 4, or my patient I presented who had suboptimal cytoreduction, residual disease, partial responses, versus lower risk patients who were stage 3, primary cytoreduction, no gross residual. That was 44% of the women on SOLO 1 were these kind of lower risk patients. And you can see that even though the clinical prognostic factors are still important, these curves are different, to the benefit of PARP inhibitor is the same. And so the risk, clinical risk of a patient does not determine the magnitude of benefit of PARP. The molecular profile of the tumor does. And so we don't want to overthink who should get a PARP and who shouldn't get a PARP based on who needs it more, who needs it less. They all need it. They all have a 70% reduction in the hazard of progression. And it hopefully, fingers crossed, will result in an overall survival advantage, which we won't know until 2023. Now, we updated the data. As I told you, there were no new safety signals, which isn't surprising because patients have been discontinued at 2 years or before. But importantly, we saw no additional cases of MDS or AML. And that's in contrast to SOLO 2, where the prolonged follow-up did show an uptick in AML MDS. And why is this? Because 50% of our patients have not recurred and received additional platinum-based therapy, which is highly correlated with development of AML MDS. So if we cure more patients in the front line, we are going to prevent subsequent development of treatment-related myeloid neoplasms if they don't need additional treatment. But certainly we're still following this, but very reassuring that we haven't seen an uptick in this often lethal adverse event. So that's SOLO 1. Then we had, and that presented, of course, in 2018 and led to approvals in 19. And then in 2019 at ESMO, we had PRIMA and Paola presented, which expanded use of PARP inhibitors appropriately to more women with epithelial ovarian cancer. PRIMA used the PARP inhibitor Niraparib, but different than SOLO, where you took women with advanced disease or had received platinum-based therapy, were in response, either partial or complete, and randomized them 2-to-1 to Niraparib maintenance versus placebo for initially 3 years, and then that was amended to PARP forever for those who were benefiting. And the endpoint is progression-free survival. Now, importantly, this group was stratified by not BRCA, but homologous recombination deficiency as measured by the Myriad assay with a score of greater than 42. And the statistical endpoint was progression-free survival in the intention to treat group and the group that was homologous recombination deficient. Now, this is a very different clinical prognostic group than SOLO. There are a couple key things that I just tell you so you don't compare medians. This is an entirely different patient population. 70% of them receive neoadjuvant chemotherapy. I have never seen that high a rate in any study. So this is a much clinically higher prognostic, higher risk group than SOLO or Paola. 31% came in with a partial response and 35% had stage 4 disease. And this was purposefully done by the company and by the study design to really enroll women that had very high risk disease, and they're randomized to Niraparib or placebo. And here are the results. In the overall population, you see a 40% reduction in the hazard of progression or death with the addition of Niraparib. So that's pretty substantial. More substantial is in the homologous recombination deficient population, which includes BRCA-associated cancers. Hazard ratio is 0.43, so almost a 60% reduction in the hazard of progression or death. And those are your two primary endpoints, and that is why, at least in the United States and other parts of the world, this has led to an approval in all comers, not biomarker driven. But we do have biomarker data, and you can see it here. On the left is the BRCA-associated cancers with a hazard ratio of 0.4, so a 60% reduction in the hazard of progression or death. In the middle is the group that we have now identified. We didn't know about this group before. This is BRCA wild type, but homologous recombination deficient. And as compared to placebo, use of Niraparib reduces the hazard of progression by 50%. That's substantial and really becomes a standard of care and maybe the standard of care. And surprisingly to me, but probably related to the imprecision of the assay that I think Dr. Scott will address, is in the homologous recombination proficient subgroup, you still saw a hazard ratio of 0.68, which is not shabby when you consider for bevacizumab in PFS, the hazard ratio is 0.7 to 0.8, and we all thought that was reasonable and led to an approval. So even though it's a gradation of benefit, all groups benefited, which is why it's not biomarker directed. And that led to the approval in April of 2020 in the United States for all comers, high-grade epithelial ovarian cancer. So our patient, let's come back to our patient, who's a germline BRCA2. She's responded beautifully to her paclitaxel carboplatin. What would have been next for her is that she has 2 approvals for monotherapy switch maintenance, either Olaparib or Niraparib. Either one of them is appropriate. And it doesn't matter that she was suboptimally cytoreduced or if she'd been a stage 3 that was completely cytoreduced. Either one of these would be appropriate for her, and she would benefit substantially from their use, and so should be the standard of care. But the reality is, in my hands, if I hope not to have suboptimal cytoreduction or stage 4 or high-risk disease, but I use bevacizumab in this setting. And so that's actually what she received, in truth, paclitaxel carboplatin and bevacizumab, while I waited for her genetic testing, and then found out she had a BRCA-associated cancer. And so with Solo and with PRIMA, the question is, do you stop the bevacizumab to switch him to the PARP? Because you can't do both. You can't get both authorized, or at least you couldn't. And in many parts of the world, frontline use of bevacizumab is the standard of care, and they use, that's the only place they can use it. And so it's sort of unacceptable for them to not use it. And so that's where Paola came from. So Paola was an investigator-initiated study that said we use bevacizumab with paclitaxel carboplatin, and we just want to add Olaparib to it. And it's actually not that flippant. There's really beautiful preclinical data that demonstrates when you use an anti-angiogenic drug like bevacizumab or a tyrosine kinase inhibitor, and you induce hypoxia in the tumor, that downregulates a lot of the proteins that are involved in DNA repair and induces a BRCA-like state into which a PARP inhibitor may be more effective. So in BRCA wild-type patients, the combination looks synergistic in the platinum-sensitive setting. So there is science behind this as well. So Paola was designed before Solo 1 resulted to allow anybody who responded to paclitaxel carboplatin and bevacizumab to randomize to bevacizumab alone or Olaparib and bevacizumab, and it was stratified by BRCA, which of course you would never do now because everyone should get a PARP, but in the day we didn't know. So you do have patients with BRCA who didn't receive a PARP on this study, and the primary endpoint was progression-free survival in the whole group, which you see here. So this is bevacizumab and Olaparib in blue versus bevacizumab in red. So this is not versus placebo, it's versus an active control, and the hazard ratio in all comers is 0.59. So 41% reduction in the hazard of progression or death over bevacizumab alone. That's pretty striking. And that was the primary endpoint, and honestly, we all thought that it would get an approval in all comers. Here are the exploratory, non-hypothesis tested subgroups. On the left, you see the BRCA-associated cancers with a hazard ratio of 0.33. In the middle, this group that I'm really interested in, BRCA wild type, but HRD, hazard ratio 0.43. So adding Olaparib to Bev over Bev alone reduces the hazard of risk of progression by almost 60%. That's very striking to me. Subgroup analysis, though. And somewhat surprisingly, as compared to PRIMA, we saw no benefit over bevacizumab alone in this homologous recombination proficient or unknown group. And that's kind of a mystery to us why that was. But based on this, the FDA decided that we only could use this in patients who are homologous recombination deficient, of course, including BRCA. And so that's our current indication. And so how do we interpret Paola versus Solo then in a BRCA-associated cancer? And so can you say, well, both of them had a hazard ratio of 0.3 in the BRCA subgroups. Of course, Solo was all BRCA. So does that mean there's no benefit for bevacizumab? Is that what that means? And you really can't look at it that way, because you can only, the hazard ratio tells you the reduction in risk of the experimental arm versus your control in that population in that study. So all we can say in these two studies is that both experimental arms reduced the risk of hazard of progression by 70% as compared to placebo in Solo 1 and Bevacizumab in Paola 1. So unprecedented benefit, but you can't compare them and say one is better than the other. But we tried to do that anyway. And so what I'm showing you here is on the right, because Solo 1 and Paola were both done by AstraZeneca, we had all the individual patient data. And so we could take the patients on Paola, who you can see in green, in the green survival curve, that had BRCA-associated cancers and received Bevacizumab and Olaparib. And then we could take patients from Solo that got Olaparib and clinically looked like those patients who had been enrolled to Paola. So we tried to recreate the missing arm of Paola, which was a monotherapy Solo arm. And you can see that in orange. And then we reran the progression-free survival curves, and you can see a hazard ratio of 0.71. So the addition of Bevacizumab does look a little better, but it's probably additive. It looks additive. It doesn't look synergistic in a BRCA-associated cancer. So what that means is you can continue to dissociate your decisions. Bevacizumab, if you use it in everyone, keep using it. If you never use it, that's okay. The important thing is the patient gets a PARP inhibitor. If you use Bevacizumab in higher clinical risk patients, that's fine. And then you identify that a BRCA-associated cancer, you have the data for efficacy and adverse events to layer on Olaparib in this case and feel good that you're doing the best thing for your patients. So at this point in this population, you can dissociate your decision for Bevacizumab and PARP. Now, how about this group of patients who are homologous recombination deficient but BRCA wild type? Based on data in the platinum sensitive space in BRCA wild type, the combination of Bevacizumab or Cediranib with a PARP inhibitor does appear to be synergistic as compared to additive in the BRCA-associated cancer. So there does appear to be this synergy in at least the platinum sensitive space, which makes me really interested in this question here. But unfortunately, PRIMA and Paola, of course, were different companies. We don't have individual patient data. And there's such different populations that you can't do, and I didn't do any fancy layering of the survival curves over one another because it's completely non-informative. They're just too different of populations to say. So I think at this point you have to do the same thing and dissociate your decisions about Bevacizumab and PARP. But this is the group that I really wish we would do a trial in, BRCA wild type HRD positive monotherapy PARP versus PARP Bev. Because if it's synergistic, that would change my behavior about how I use Bevacizumab. But at this point, I just have a suspicion, but not facts. So this is a data-free zone. And then, of course, there's PRIMA where you can just use monotherapy PARP in anyone, and you don't even need the biomarker to make your decision, which makes it nice in parts of the globe where HRD testing is not available if you want to use a PARP for your patients. But this group of women in the front line is kind of who need our help the most. And this is the homologous recombination proficient tumors, which we all have. I have included Velia here. I didn't talk too much about it because it's not being put forth for FDA approval, but just to show you the curves, PARP works okay here, except in Paola, but you can really see the clinical prognostic significance of identifying a homologous recombination proficient tumor. And so we were all hoping that immunotherapy would be the answer to this. And we ran two studies, Javelin 100 and Imagine, incorporating immune therapy either by itself or with Bevacizumab in all comers with high-grade epithelial ovarian cancer, and it completely did not work. Javelin 100, in fact, looked like patients who got immunotherapy did a little worse. And Imagine 50, which I actually am very proud of and ran this study. I'm glad that we didn't harm anyone, but we certainly did not benefit them with the addition of atezolizumab, somewhat surprisingly. And the overall survival thus far is very immature for both studies with limited follow-up. But there is this question with all immunotherapies whether or not we'll see this differentiation in the tail of the overall survival curves, which requires, of course, a restricted mean sorts of analysis and a lot of follow-up, and is of great interest in other solid tumors. I would be surprised, honestly, if it were the case here, but we'll see with follow-up of these studies. But I'm not holding my breath for this one. And there were no signals in subgroups either in PD-L1 positive and Javelin 100, and imagine 50 PD-L1 positivity was fully powered primary endpoint, no statistically significant benefit. Even in the highest group of PD-L1 positivity, there was a little bit of a signal, but in an exploratory non-hypothesis tested analysis, these are rarely proven, actually never has been proven true in prospective testing. So the likelihood that this is real is low, and it's only 20% of the population. And then germane to this conversation, there's been a lot of preclinical work, again, beautiful work that would suggest women with BRCA-associated cancers would be the one to benefit from immune therapy. And it was shown several times in preclinical models, modest signals in recurrent disease and absolutely no signal in the frontline. The BRCA who enrolled on Javelin 100 and Imagine did not benefit more, but they certainly didn't benefit more from atezolizumab than those who are wild type. And so what happened here, ovarian cancer is just not small cell lung cancer or melanoma and has a very low probability of responding to immune therapy at baseline. There's a lot of stuff in the microenvironment that may explain this. For example, this is a mistype. It should be fast ligand or VEGF may impair T cell trafficking to the tumor. Although if this were the major obstacle, Imagine 50 should have worked. And then we just don't have biomarkers for this. And there's a lot of work that's beyond the scope of this talk, but we just can't, if it's going to work in anyone, we don't know who they are yet. And so we really have to think before we run another 1,000 patient study with immune checkpoint inhibitors. So one of the things that I always say in these talks, and I'm going to finish, is that one of the halo effects of all of this great work in PARP inhibitors have been that we've actually started testing women more and more. It's actually essential to offer testing and make sure that all patients who want it are tested so we can do cascade testing and prevent these cancers from ever occurring and create previvors, as my friends at MD Anderson like to call them. And so we are increasing our numbers in terms of BRCA.
Belief that it was really high. Then at ASCO this year, there was this paper presented that was really just depressing in that as of 2017 and 18, we were still at only 50% testing in the United States,
despite this being in the NCCN guidelines that it should be universal since 2010. And despite all the work leading up to SOLO-1, in the recurrent setting, we were still sitting at 50%, which I find embarrassing, quite frankly. So I was a little dismayed by this, and I like to put this in here mainly for US audiences, to make them sad if they're not testing. And it's just all the things that are embarrassing. We weren't testing older women or women with comorbidities, med-onc and gyn-onc. There was no difference. We were equally as bad, unless you're at an NCI designated cancer center where there are probably procedures in place to make sure this got done, but really not a good presentation. And so I'll end on that low note. Sorry. But I thank you for your attention, and I think I'm right out of time, but I'm happy to take questions now or later. Thank you so much.
Thank you so much, Kathleen. It was a fantastic talk. And we can see that the research have made a lot of progress in the last 5 years. So I can't see any questions yet in the Q&A, but I can start with a couple of questions. So do you think PARPi as a frontline therapy may be able to replace chemotherapy?
I think that's a great question. Yeah, I think it's a great question. And, one of my good friends is Shannon Weston and MD Anderson, and she's been a huge proponent of this for a while and actually has a trial running at MD Anderson for women with BRCA-associated cancer only, where they're getting neoadjuvant chemotherapy and they're running in with a PARP instead of chemo to the point of the interval surgery to look at response rates and comparisons to chemotherapy, trying to really show feasibility that it can be done. And there's another run at that from another company that's not quite in the public domain yet. So I'm interested to see the results of those studies. It certainly should work. The response rates are incredibly high, especially in Ursula Matulonis has shown this beautifully, that the earlier you use a PARP, the higher the response rates. So the frontline should be your ideal place to use it. It's kind of question of feasibility, and is it just for BRCA or is it BRCA and HRD? And, do you get the same really big reduction in ascites and tumor burden that you really need? Because as you know, these patients, some women sometimes come in so sick, and you need to get a rapid response so they feel better and they can sort of get their nutrition back up. Is it a select group that can do this? Is it everybody? We're just starting those trials, which is exciting.
We have a couple of questions here from Anna DeFazio. First, thank you for great presentation, Kathleen. Is there a difference in response to PARPi maintenance depending on whether the patient has upfront debulking or neoadjuvant chemotherapy?
Yeah, that's a great question. So and I went over this kind of fast. So clinical prognostic factors are still very important, clearly. So if you have someone that has such high burden of disease that they have to get neoadjuvant chemotherapy, or, in this day and age, there's fewer and fewer getting suboptimal side reduction because of all the laparoscopy we're doing up front. But, these kind of clinical poor, stage 4, clinical poor prognostic factors, that still impacts outcome. So that is true. We can't eliminate that prognostic impact. But the magnitude of the benefit in a patient like that versus a patient who's stage 3 primary side reduction to no gross residual, in BRCA, the best prognostic group of patients you could ever hope to treat, the magnitude of the benefit is the same. So the amount you bump up both of those groups with a PARP as compared to placebo or even bevacizumab is the same. So I would say the impact is the same, but their progression-free survival is still different because of the impact of those clinical factors. And we haven't been able to fix that yet.
A question here from David Botel. Hi, Kathleen. So given the disappointment of immunotherapy combination, where to next?
Yeah, I think that there's a lot going on that's exciting. Some of it's not quite in the public domain yet, so I can't say. But there were a couple interesting presentations at ASCO that I took out in the interest of time, where instead of looking at traditional immune checkpoint inhibitors, and we all know how these work, you have to have an activated immune system in the tumor for those to work. And ovarian cancer, for a variety of reasons, just doesn't. And so a lot of effort has switched to adoptive T-cell therapies, and those studies are starting in ovarian cancer, and then like dendritic cell vaccines and other kind of vaccine strategies. So the Sotio pharmaceutical company presented their dendritic cell vaccine randomized phase 2 data at ASCO, and it's small. Randomized phase 2 are fraught with bias because they're not stratified, but they did show progression-free and overall survival in women who had low, I think it was low CD8 T cells in their tumor at baseline, actually in all groups, but the biggest benefit was in that group with sequential use of their vaccine. And so we may see that coming up, and could that be mixed with a PARP is interesting. And then similarly, the Gradalis vaccine out of the Vigil study, which was a negative study, and that's an autologous T-cell vaccine. But they looked at their homologous recombination proficient subgroups, an exploratory analysis, but in that subgroup, PFS and OS did appear to be improved with the vaccine. And so that has both those have to be validated, but kind of coming at the immune system differently. Kunle Odunse has done amazing work with NY-ESO, targeting that. You can make CARs towards that. That's where the studies are now. And I think they're small, and we're going to have to see if there's a signal there, if immune therapy is going to work. So there is a lot of work going on now with adoptive T-cell therapy, and I'm excited about that. I'm a phase 1 trialist, and so I have some of those open at my site, and our patients are really interested, although they're not for everybody. So I think that's sort of one strategy for immune therapy in particular, and in particular for homologous recombination proficient patients. I'm interested in that group.
A question here from Naisana. Thank you for the presentation. So based on the data presented, do you think the angiogenic treatments should be combined with PARPi? Yeah,
so for BRCA-associated cancers, I really do dissociate my decision. Like, I'm going to decide. I use Bev a lot because I like it. In my part of the world, I don't get a lot of these low volume disease. They come in really late. So So almost all of the patients in mine and my partner's practices are clinically very high risk. So we use a lot of bevacizumab, not in everyone though. And then we can layer on the PARP if the tumor has homologous recombination deficiency or BRCA. And I feel good about that. For HRD BRCA wild type, I'm really interested in whether there's synergy. And I'm not going to lie, based on the platinum sensitive data that Joyce Liu has shown and Mansoor Mirza with either Bev, Niraparib, or Cediranib Olaparib, that BRCA wild type group really looks synergistic to me. And I'm just wondering if there's synergy in the front line. So I have added in Bev at the end so I can use both without any data. I'm just going to acknowledge that. And I really, really, really want AstraZeneca to run that study because that would change my practice. If there's synergy there and someone is appropriate for bevacizumab, even if clinical risk factor wise, maybe I wouldn't have put them on it. If there's synergy, I'm going to talk to that patient about the combination because it does have increased toxicity. So if it doesn't help, I don't want to use it anymore. But if it's synergistic, I want to talk to patients about it. And that would change my behavior about Bev in that group, which is 20% of our patients. So I think that study still needs to be done. We just don't know if it's synergistic or not.
Yeah. And if I could have one last question. I mean, we know now about the data of PARPi combinations like with ATR inhibitor or WEE1, or now we're going to hear from Alan about Pol theta inhibitors. So, is that going to complicate decision making, or how do we decide which is the best combination forward?
Yeah, there was great data presented at ASCO with the Capri phase 1, small data. So Capri was presented, which is ATR, ceralasertib, and Olaparib, with a very high response rate. Platinum sensitive patients, but they all had progressed on PARP. So they were PARP resistant, and you still saw very nice response rates in this platinum sensitive population, and that needs to be validated. And then the EFFORT trial was presented by Shannon Weston, which is also tumors that were PARP resistant, WEE1, adavosertib, and PARP, with really 30 and 38% response rates in that. And most were PARP platinum resistant too, but not all, about a third are platinum sensitive in the BRCA wild type, which is very interesting. And I've not ever seen response rates of adavo alone that high. So I'm really interested in that data. I think those are more strategies for post-PARP. Those may be strategies which we need now for women who get PARP in the front line and now they've recurred. What am I going to do? These may be strategies to develop there. And then we have to see what's helpful. Panos Konstantinopoulos has a study that is moving through NCI that's pick 3 PARP in a post-PARP setting with beautiful preclinical data there as well. So there's quite a few options really gunning for that post-PARP place. Now you're going to hear about Pol theta. I'm so excited about Pol theta. I don't think I'm just giddy about it. And I'm so excited that I think I'm going to get to have the study open. Pol theta is so interesting in that it may help us prevent reversion mutations or hopefully overcome them. And so, in SOLO-1, which is amazing, if I do say so myself, but 50% of women have progressed at 5 years. So what if I could change that? Or what if I could add something in when they do start to progress, or I see that CA-125 goes up, that I could arrest that? So that's really exciting. I don't think ATR and WEE1 are going to be there, although they might be if we can figure out the toxicity profiles, but Pol theta might. So I think that the world of kind of adaptive clinical trial design, where we kind of add something into PARP when we see either circulating tumor cells or some other serum marker start to go up, and we add something in that addresses what's happening, that may be coming. And so I think that there's 2 different strategies based on what's being developed. I'm super interested to hear what Dr. Andrea, he's brilliant about what he thinks about Pol theta, but that's really one of the most exciting assets that's under development right now, in my opinion.
Thank you very much. Thank you for a fantastic presentation.
Thank you for having me.
Thank you. We'll move on to Professor Claire Scott's presentation. I've known Claire for many years, and I'm always inspired by her passion and dedication for improving outcomes for women with ovarian cancer and rare cancer. Professor Claire Scott holds the chair in gynecologic cancer at the University of Melbourne and is Joint Division Head of Clinical Translation and a lab head at WEHI and medical oncologist at the PRIMA, Royal Women's and Royal Melbourne Hospitals. Claire's lab focuses on drug resistance in ovarian cancer and other rare cancer types, generating patient-specific models to understand and avert resistance to targeted therapeutics. And in particular, she has been a leader in developing PARP inhibitors therapy for ovarian cancer, which has, as we've seen, it has resulted in unprecedented efficacy. Professor Scott has received numerous fellowships and awards, and she's a fellow of the Australian Academy of Health and Medical Sciences. And the title of her presentation, Understanding HRD in High-Grade Serous Ovarian Cancer and its Impact on Treatment Choices in Early Lines of Therapy. Over to you, Claire.
Hello, everyone. It is a great honour to be here, and difficult to go between these two outstanding international speakers, even more difficult to share my screen appropriately. So just one moment while I work out which button to press.
Hi Claire, just go down out of that browser and around there, if that's okay. Just down a little, not that one, hide that. So I can see just in the background, so a little bit more down. Yeah, and to your left a little bit.
Stop share?
No, bit further. A bit further. Yeah, and just click on the PowerPoint button.
Oh, click here.
Yep, that should open up. There you go.
Okay, and then is that great? Is that correct?
Loud and clear. Good to go. Thanks, Claire.
Okay, great. So great. Can you see my disclosure slide?
Yes, we can.
Great, thank you very much. Sorry about that. I really wasn't sure what you were able to see. So as you know, my title is about understanding homologous recombination deficiency in high-grade serous ovarian cancer, and most importantly, its impact on treatment choice. And we're focusing on the early lines of therapy, but as you all know, that's first line and then second line and beyond. And we have some really difficult treatment choices. They're incredibly important for our patients. And we're focusing on high-grade serous ovarian cancer today. This is the most common epithelial ovarian cancer subtype, and it's been so beautifully introduced by Kathleen. It's aggressive, often diagnosed at an advanced stage, and really importantly for all of our clinical thinking, we need to understand the molecular characteristics. So thank you to David Botel, who, as we know, is in the audience because he just asked a question. He and his colleagues showed us that it is ubiquitously involved with P53 mutations. And we know now so much about the 50% of these cancers that have homologous recombination gene defects. So very famously, these involve BRCA1 and 2. We know much more now about RAD51C and D. This 50% kind of theory about involvement is a moving or shifting sands really about what genes are involved. But if you have a look at these genes here, BRCA1 and 2, BRCA1 methylation, I'm going to talk about RAD51C I just mentioned. There are some other core RAD genes that I'm going to show you and some other DNA repair genes, which Liz Swisher has been very capably bringing to the fore here. CDK12 that we'll talk about, some Fanconi genes. The MZ amplification, we've attempted to address in the literature ourselves. It remains really undefined and probably not important. P10 loss is potentially not entirely relevant. So it is possible indeed that in the recurrent setting at least, BRCA1 methylation accounts for quite a chunk of that. So high genomic instability is another way of thinking about this. So homologous recombination is a pathway that is integral for core repair in a high fidelity sense. The non-homologous end joining pathway is also important, but in a non-high fidelity way. Now, we're thinking about PARP inhibitors today, so we have to think very carefully about synthetic lethality. And the way you think about that is to think that you, in that sense, can have a requirement for one component or another. But if you lose both, then something very bad or good, depending on which way you want to think about it, happens. And that is indeed the way PARP inhibitors came into being when it was proposed that they might be useful for treating ovarian cancer. So the PARP inhibitor mechanism of action, the PARP family are DNA damage sensing proteins, and in this setting, PARP inhibitor selectively kills cells which have a defect in homologous recombination DNA repair. And we certainly believe this for BRCA1 and 2 defects, and also for RAD51C and D defects, and I'm going to come to that during my talk. So the current theory of PARP inhibitor mechanism of action is that PARP inhibitors trap PARP1 on DNA. This blocks DNA replication fork progression. DNA double-strand breaks accumulate. These can't be repaired by HR. This leads to genomic cellular toxicity. And the most commonly used PARP inhibitors in the clinic, as you've heard, are Rucaparib, Olaparib, and Niraparib. So we get this, in effect, PARP inhibitor effect, which leads to cell death. So I'm going to base much of my talk from this ESMO recommendation article that was published late last year in Annals of Oncology, because this deals with this issue we have about using the concept, or indeed the reality, of HRD as a biomarker for PARP inhibitor benefit. And that is the focus of my talk today. It is much easier to give it after this beautiful talk we've just heard from Kathleen and the setting of the PARP inhibitor trials. But in fact, everything that I'm going to say really comes from the analysis of HRD in the setting of the trials that have just been so beautifully introduced to us. So I'm going to touch on the talks, but touch on the trials, but of course I don't need to describe the trials because you've just heard them. But it's very interesting to pause and reflect on the fact that we can't view biomarkers without understanding their analysis within well-designed and very beautifully analysed clinical trials. So just very briefly, contemplating HRD and HR itself, you have to look at the process of homologous recombination. And here we have BRCA1, BRCA2, and the Fanconi anemia complex doing their stuff at a break in DNA, a double-stranded DNA, and you have one strand being repaired off the back of another strand. And so when HR is proficient, this is error-free DNA repair done on the left-hand side. And if there are mutations, then this will be a functional HR deficiency. This is an important slide because it's the only time I'm going to actually talk about the different tests and the different terms used. So here you have LOH and other terms here which are defined. So NTAI are the number of subchromosomal regions with allelic imbalance extending to the telomere. So this is the T here. LST, which are large-scale transitions. And all of these together are termed genomic instability scores. These are genomic damage, and these form various composite tests. So GIS and BRCA1 and 2 mutation itself, which is obviously the straightforward mutational analysis of BRCA1 and 2, go to form the myriad My Choice test, which many people are familiar with, but used particularly in areal 2 and 3 is the Foundation Medicine NGS assay, and that is an LOH score, which you see up here, where you can see that these are large chunks of the genome which have undergone LOH, and a specific cutoff was set for that during the areal 2 and areal 3 trials. And so that was the LOH score plus BRCA1 and 2 mutation. So that's the difference between the Foundation Medicine assay and the Myriad MyChoice assay. HR Detect is different. So that uses whole genome sequencing from all 4 mutation classes and measures 6 independent genomics features. Signature 3 you may well have heard of. So this is a measure of integrated genomic signatures, one of which is HR Detect, but you may independently hear about Signature 3 being mentioned and analysed as a potential test for the future. We're not really going to talk about that at all any further today, but just to mention it here as being something that we do look at when we talk about whole genome sequencing. But for the rest of today, we're going to be focusing on HRD as measured by either Myriad or Foundation Medicine, depending on which trial we're talking about. And very often in the clinic, it's Myriad MyChoice, which is being used by many of you in the clinic, because that's often the thing that has been used as a copay by reimbursement approvals. So this then is just really putting those 2 previous slides together and saying, if we then look at a functional HR deficiency, we are thinking about the etiology of HRD, we're looking at functional assays such as RAD51 assay, we're looking at genomic scarring, and then we're looking at composite tests. So that is what we're going to be thinking about going forward when talking about HRD, thinking about the trials and thinking about what we're looking at in the patient subsets. So when we want to talk about HRD testing and working out whether we can actually establish PARPi benefit in ovarian cancer, we have to think about the patient subsets with ovarian cancer. Are they PARPi sensitive? Are they platinum sensitive? Do they have HRD? These are all concepts that we're used to talking about and thinking about in the clinic. So what HRD biomarker did we actually use? What is the HRD phenotype these patients have? Can we predict PARPi response? Do we need better prognostic information? What is the treatment stratification that we've used? And are we looking at the primary or relapse setting? These are all questions discussed in this paper. They're actually all questions that we think about every day in the clinic. We're going to be looking at clinical validity and clinical utility, and I'll describe that as we go through. So this then looks at the different type in this table here, just at BRCA mutations in the first part, and then non-BRCA mutations in other HRR genes. And I'm going to take you through the evidence for that from a number of different sources. So starting off with the easy one, germline BRCA1 and 2 mutations. So throughout my talk, even though I don't like the acronym BRCA, and those of you who know me know that, I will use it for the purposes of efficiency, which I guess is why everyone uses it. So for germline BRCA mutations, we have a high level of clinical validity and clinical utility in the first-line maintenance setting and in platinum-sensitive relapse disease. So we're all happy with that, and I'll show you the data as we go through. For tumor BRCA mutations, we also have that. For somatic BRCA mutations, which are defined, so tumor BRCA mutations, by definition, we haven't yet done a germline test, but by the time we have defined the tumor mutations as being somatic, by doing the germline status, we also know then that the tumor mutation is somatic by definition. We have good clinical validity, and certainly the utility is good. Now, for these non-BRCA mutations, I'm going to take you through the evidence, and ultimately we have some evidence for some of them, but very poor evidence for others. And then for the genomic scar assays, you've just seen some of the evidence presented by Kathleen, and I'll take you through some of that as well. So you'll see a lot of forest plots like this on the way through from different groups. So this has been put together, as I said, for this particular publication. This looks at, and you'll see this coming again and again, the Ariel 3, NOVA, Solo 2 study, and study 19. So these are the 4 studies included in this paper. And what we're looking at here is pretty much the BRCA testing and LOH high BRCA wild type and LOH low BRCA wild type groups. I'm going to show you other plots like this with other endpoints, more specific for other gene subsets and other molecular subsets. So you're going to see a similar, forest plots and similar trial groups, but with different molecular subsets. So just getting your eye in might all start to blur. So what you can see here is boxes tell you how big the patient subgroup is by the size of it, and the colouring tells you what the different molecular groups are. So here you can see that the very impressive favouring PARPi, the further to the left it is. So clearly BRCA, which is in dark purple, did the best. So BRCA always did the best for all of these. So this is in the relapse setting up here and the first line maintenance trials down here. So BRCA always did best, not surprisingly, and this is germline and somatic together. And here you have LOH high in, but also including germline and somatic BRCA. So here you have LOH high, this one here in the light purple, you have LOH high and BRCA wild type, but here in green, you have LOH low and BRCA wild type. So you're losing some of the benefit once you have LOH low and BRCA wild type, but still, as Kathleen said, you have quite a significant benefit. And so you see that pattern being repeated, but you can start to see that you definitely lose benefit. And as you go down in the first line setting, you see again this pattern repeated. So I'm going to move on because you're going to get a lot of repetition going through, but some of the story that I want to pull out of this becomes more apparent. So the reason I've put the SOLO-1 trial in, knowing that Kathleen would have spent some time talking about it, the point I wanted to reiterate was that here we have an increased chance of cure. And I wanted to make that point because this is absolutely unprecedented and it gives us something to hold on to and something very real that we have a chance of spreading, metastasizing, if you like, into other patient groups. So SOLO-1 is purely for BRCA, BRCA1 and 2, either germline or some somatic, but it's just restricted to BRCA1 and 2. But the point is, can we ever spread this to other subgroups? So RAD51C and D potentially, is there anyone else that we can hope to cure with PARP inhibitors? And reiterating that at this 48% at 5 years, that's half our patient BRCA group. What happened to the other half, and can we ever do this for non-BRCA patients? So this is my remit to look at the HRD group. Are there other patients in the HRD group that we can convert? So these are slides that Eric Bouchard-Lorraine very kindly gave me from his presentation at SGO earlier this year. And it has a very negative title, but I'm not going to be entirely negative about his slide set. So if you look at the title, Homologous Recombination Repair, Mutation Gene Panels, excluding BRCA, so we've lost that perfect group that I've just shown you, are not predictive of maintenance Olaparib plus Bevacizumab efficacy. So this comes from the Paola 1 trial. So straight away, we've got a problem, but can we fix any of it? So these are the HRD positive patients, including BRCA mutant. But if we take the BRCA mutant out of it, we're left here with the HRD positive patients excluding BRCA. So you can run a truck through here. You can run a small truck through here with an HR of 0.43. So the purpose of this sub-study was to look at a predefined exploratory gene panel. And there was great excitement. We're all excited. What are these other gene mutation high-grade serous ovarian cancer is going to do when faced with a PARP inhibitor? And there are some genes in here that we love. PALB2, RAD51C and D. What about these other genes? And then there was an expanded panel. So genes added in here, some of these FANC genes, what about Bloom? And then a restricted panel of maybe our favorites. Some published panels used in other trials. So lots of ways of dicing and slicing and cutting the cake. Another way of looking at it, HRD positive versus HRD negative, and of course some unknowns, and this divided into TBRCA and non-TBRCA mutant. So I've only shown you a subset of the slides because I don't have time, obviously. So if you look here, you've just added into these HRD positives the patients within this trial who are actually found to have these mutations. Now, the first thing to say is those percentages look really small, but actually the numbers of patients, you know, there are still tens of these patients, hundreds, but tens, that's still actually quite a lot of patients, but certainly low percentages. So that was somewhat, you know, disappointing, but actually we knew that because we know it adds up to, you know, maybe 6 to 8% is what we were looking for. So the percentages look smaller than that, but never mind, because we're already selecting, sub-selecting by having patients selected for a trial. But the issue is what was happening to these patients. So if we look at here and we look at a GIS score, so there's a genomic instability, and remember I showed you that this GIS is kind of a way of reducing based on those original definitions, but genomic instability is where the action is. So this is where the action is, and look at the genes. Oh my God, they're my favorites. How fantastic. So my favorite genes have genomic instability. That's really cool. So maybe these genes are where the action is going to be. So let's just look at them. Bloom, not so sure. Actually, you know, I've been worried about Bloom for a while, so maybe that one's going to drop out. I don't know. BRIP1, well, I'm a bit of a family cancer clinic person, so BRIP1's been a bit dodgy for a while, but I'd certainly pay for RAD51C, PALB2, and RAD51D. Definitely had, you know, anecdotal long-term responder on PARP1 for PARP inhibitor for PALB2. So I'd pay for 3 of them. Now the other genes, maybe I'm not so surprised about those falling below the GIS line. Anyway, this is the data. Nothing, absolutely nothing, and nothing for the restricted panel. But if you look here, this is HRD positive. So what's different here? So what's different is that the HRD positive patients have been chosen first based on an HRD positive test. So remember, this test is not biased by having to have an HRR mutation. And if you look down here at the numbers, so this is small numbers, right? Aren't hundreds of patients here, aren't even tens of, well, small numbers, right? So these are HRD positive patients who then have an HRR gene mutation. And we're not being told which gene mutation. So maybe they've got my favorite gene mutations, but I don't know what they've got. But when you pull it out this way, when you slice and dice based on biology, now you can run a small van, maybe man with a van. You can run that through. So this tells us there's something going on, but we actually don't quite know what yet. These numbers are pretty small and they're not telling us the answer, but there's some hope there. So what are the genes responsible? Maybe that GIS information told us that some of our favorite genes might be in there. So what other data have we got for this? What are the HRD aberrations that might be here? So I'm just very quickly going to tell you a little bit of PDX data. As you know, I love PDX. So we published back in 2017 that RAD51C and D were bona fide mutations for PARP1, PARP inhibitor sensitivity, and secondary mutations in these 2 genes could confer resistance to PARP inhibitor. And this was published in Cancer Discovery. I don't have time to go through the evidence, but because of our evidence, this was the first time that RAD51C and D could be shown to be bona fide mutations for PARP inhibitor sensitivity and susceptibility. What about epigenetic silencing of BRCA1 and RAD51C promoters? We also, using PDX, provided evidence that these genes, that methylation was also a core mechanism of PARP inhibitor susceptibility, but in fact you needed full homozygous silencing, and we demonstrated that zygosity was important. We used the Ariel 2 Part 1 trial to access patient samples to prove that samples that were silenced in a homozygous fashion with high confidence were exactly similar to BRCA1 mutant cases, and that anything that was less than that, so potentially heterozygously silenced, was similar to wild type cases. And this was the first time that BRCA1 methylation had been used to predict PARPi response, and the first time that anyone had considered that methylation zygosity as a concept was similar to mutation zygosity. So this actually explained the dichotomy in the literature. We also showed that BRCA1 methylation loss can happen after exposure to chemotherapy, and that was really important because it meant that these patients needed to be treated early in their patient journey, because loss of methylation of just one copy of BRCA1 was enough to cause resistance. So there was no point treating these patients later. They had to be treated early. So in first-line maintenance, for example. Now this needs to be validated in more patients before it could be absolutely accepted in the clinic. But it's just worth pointing out that in Australia, we have first-line approval for BRCA1 and 2 mutated high-grade serous ovarian cancer. That's 22% of patients, but BRCA1 promoter methylation accounts for about 12% of patients, and they, at this point in time in Australia, don't receive PARP inhibitor therapy, and yet they desperately need to be treated early, not late. So what about RAD51C? Well, we've just completed the work for that, and it's just been accepted for publication in Cancer Research. We've validated it in patient samples, and we've found a new pattern of methylation, which we've termed heterogeneous methylation, and both homogeneous, which is the normal pattern, and heterogeneous methylation are susceptible to PARP inhibitor when homozygous, but they can be lost under PARPi treatment pressure and potentially platinum treatment, and when lost, the same fate happens. So if they're heterozygous, that breeds resistance. And we have the EMBRACE clinical trial of Olaparib in Australia at the moment, studying both BRCA1 and RAD51C methylated breast and ovarian cancer in order to better understand this. So just very quickly, the Ariel 2 Part 1 and Part 2 translation has just been published by Liz Swisher and us, and in Nature Communications. And this shows a number of things. So this is the BRCA mutant high-grade serous ovarian cancer, and when it's sensitive compared to the resistant refractory cases, you can see that they do much better with PARP inhibitor, again showing why you should treat early. This shows that the Part 2 cases had been heavily pre-treated compared with the Part 1 cases, and this is a forest plot proving that for all molecular subgroups, so here we have platinum status, number of prior chemo regimens, you can see that the BRCA mutants, this is overall response rate. So this forest plot goes the other way. So to the right is better than to the left. So BRCA mutant does better in every sense. I've highlighted the BRCA mutants. This is somatic here. BRCA mutant. Here you have RAD51C and D pulled out, and that was the point of showing you this. This is the BRCA1 methylated, and this is defined as high or low. So they didn't do the arduous homozygosity, which takes a bit more work, just crosses the line. But I'd argue if you did homozygosity, it wouldn't. I suppose that's my bias. So this was showing you the RAD51C and D pulled out because it wasn't able to be pulled out in the SGO paper. This, again, is from the same paper, and this shows the methylation data. And this shows methylation high versus low. So this is the high in the pink curve here. This shows BRCA wild type LOH high in the pink curve versus resistant refractory. And this is the final piece of data I wanted to show you. So this was done by the GCIG Intergroup Meta-Analysis Committee led by Ros Glaspool. And this is a meta-analysis performed by Chi Lee here in Australia. And this was done using Ariel 3, Nova, Solo 2, and Study 19. And the reason we first initiated this study was specifically to look at a meta-analysis so that we could increase the proportion of somatic BRCA patients. because in every individual study, somatic BRCA never really had very much power. And at that point, when we initiated BAC, had not approved somatic BRCA patients, and we only had germline approvals. And we certainly knew that there were many other countries in the world, like in South America, where somatic BRCA was also not approved. It had been approved in Europe and the US, but not in many places. So we wanted to nail that and make sure there were never any more arguments. And that is the point of this really lovely diamond here. But there are other things that we've achieved with this manuscript or this paper as well. So we're going back on the left side of the forest plot curve. So here you can see this is for germline BRCA1. We also were able to pull out and separate really nicely BRCA1 and BRCA2, which is not always done. So as I said, somatic BRCA together, we couldn't separate somatic BRCA1 and BRCA2. Wild type BRCA and HRP. So if I move on one slide, and this was what Kathleen was referring to before about HRP. So I'm going to look at it in this manuscript. So we were able to really look at this. Now it slides really close to the line, and it really depends how close do you want to go. What are the numbers, and how much certainty do you want that a statistically significant difference is clinically and biologically different in this HRP group? So a lot of these do go very close to the line. Aerial 3 is clear of the line, and this is second line. In the first line, it's clearer. In the second line, there are more mechanisms of resistance. So I think in this setting, it's the HRP groups are not as clear. I'm just going to say two more things about this paper, and then I'll make a few more HRP comments. So this paper showed two other things that I think are of relevance. So this is statistically significant and not seen in other studies. So when you have more than 2 prior lines of platinum therapy, we saw a clear difference that PARPi had significant efficacy, and this is in keeping with what we understand about BRCA carriers, for example, being incredibly platinum sensitive, but this was over and above BRCA carriers. So I think that this is very interesting. And just one other thing, when looking at the HRD population, if you have a prior platinum-free interval of greater than 12 months, and I think we all know this inherently in our patient setting, that really did seem to be of interest. Now, the p-value is not entirely significant. It's 0.14, so presumably we would have needed to have more patients in order to get a significant p-value, but this HR at 0.34 is different to 0.54, and we do believe that this probably would have become significant. So it is in keeping with probably what we would think clinically, that a prior platinum-free interval of greater than 12 months, or the longer your PFI is in the HRD setting, the more likely that the patient is to respond to a PARP inhibitor. And for those of us who actually don't have an HRD test funded and available, that information is probably real and useful. So in the HRP setting, this and in a number of other forest plots that I've shown you, the all of the data is very close to the line. And I think for many of us, whether to treat an HRP patient with a PARP inhibitor is still a difficult decision to make. So the clinical trials that you've heard today have led to many PARPi reimbursements, but they vary from setting to setting. In the UK, I think really everyone is able to receive either Olaparib or Niraparib. There's no patient who doesn't receive first-line maintenance therapy of some sort. Some people are only receiving Bevacizumab, but really any patient can receive a PARP inhibitor. In the US, I think it really varies depending on habit at different institutions. And in Australia, only a subset of patients are receiving PARP inhibitor. Definitely all BRCA mutation patients are receiving a PARP inhibitor, but at our institution, very few other patients are at this point in time, and we don't have access to an HRD test. So for me, just wrapping up, the mutated BRCA1 and 2 is the key comparator, although there are a subset of BRCA1 mutated cases that can do badly, both germline and somatic, but every BRCA1 mutated case should receive a PARP inhibitor in the first line. For mutated RAD51C and D, both germline and somatic, although these are rare, they're likely to be strong predictors of a PARPi response, and we would attempt to get them access to a PARP inhibitor. All 4 of these genes, the cancers can develop secondary mutations which predict for PARPi resistance. This is why they should be treated early. Now, some other like PALB201 can predict for PARPi response through anecdotal long responses that we've seen, but this is still an area of active research, and again, we would attempt to get these patients a PARP inhibitor in the first line. Many other HRR genes on panels do not seem to play a role in PARPi response. I guess those patients should still be offered clinical trials. HRD tests predict for PARPi response. That's absolutely clear from clinical trials, especially in the first line and following along TFI. We don't have HRD tests currently available in Australia. We should be trying to access clinical trials and continue to look for how we can take this forward. The majority of non-BRCA HRD may well be homozygous BRCA1 RAD51C promoter methylation when you do the maths and work out what's left in that space. And homozygous methylation can be lost following platinum and PARPi treatment. Early treatment with a PARP inhibitor should be offered to every woman with high-grade serous ovarian cancer as early as possible, unless she develops platinum-resistant disease prior to having a PARPi. But for us, we need to do this within a clinical trial setting, unless we can access an access program. So participation in PARPi combination trials should be encouraged, and post-PARPi PARP combination trials should be developed. So there are many people to thank for involvement in our research studies, and I'd be happy to take questions.
Thank you, Claire. Fantastic talk. It's amazing that we're now starting to use the word cure when referring to treatment of BRCA ovarian cancer. There's a question here from Alan. Claire, great talk. Does RAD51C methylation correlate with the functional test, HRD or mutational signature?
So it certainly correlates with a RAD51C focus assay, which means that we no longer see foci form. That is the gold standard test. So yes, it would be expected to correlate with an HRD positive test. In terms of performing a myriad HRD test on a patient who I know has RAD51C methylation, I haven't yet done that. We are actually in the process of validating some of our cases, so that will be done in a research context soon.
Another question from Dale Garsett. Thanks, Claire. Does the zygosity of BRCA1 and RAD51C methylation correlate with HRD score? So that's yeah. So I've got a question which is really difficult in the field. I think it's the BRCA2 synthetic lethality in ovarian cancer with PARP inhibitors is stronger than BRCA1.
Sorry, can you just
yes.
first part?
So synthetic lethality of BRCA2 mutations with PARP inhibitors is stronger in ovarian cancer than BRCA1. And I think it's the reverse in breast cancer.
The synthetic lethality of BRCA2
with PARP inhibitors I think it's different from BRCA1. And it's the reverse in breast cancer.
The outcomes are stronger for BRCA2 in ovarian cancer. And I guess that's true functionally. I would agree with that.
Yeah. We still don't understand the mechanisms that really make that difference between BRCA2 mutations and BRCA1.
No, I mean, I guess that the issue is that in breast cancer, there are, I guess we think of them as different subsets, don't we?
Yeah.
So it probably relates to the original cell of origin in breast cancer. I think the biology is just completely different.
Yeah.
So I would look at the biology of the cell of origin they're almost like just completely different cancers.
Yep.
I would have thought.
So synthetic lethality is related to the biological context.
Yeah, I would have thought so.
Yeah. We have a question here from Adams. Another great talk, Claire, following a brilliant talk by Professor Moore. Are we pushing for HRD testing to be funded by MSAC and then for HRD patients to receive PARPi on PBS based on your talk?
So there are efforts underway, I think, for a number of different approaches. In terms of just thinking about our patients, it would be great if we had a funded HRD test and then drug approvals. So there's absolutely no doubt. I mean, I think the US system is quite different because they have a whole lot of different ways of funding things. But if we just look at what's happening in the UK, I mean, I've just been speaking with Ian McNeish this morning, and, you know, perhaps the UK system is a little bit more similar to ours, and they have great approvals there. They have access to the Myriad My Choice test at the moment, and then access to drug. So yeah, look, and even, you know, in India they do as well. And I think there's no doubt in my mind that if our patients could access early PARP inhibitor, particularly based on an HRD test, that would be fantastic. There's a lot of benefit to be had for HRD positive patients to have access to a PARP inhibitor in the first line. I think that's undeniable.
Mm-hmm. And a follow-up question, is Myriad your preferred platform, or is that too controversial to ask?
Look, I think if you look at the data, someone with a positive Myriad HRD test, it may not be my favorite test, but if a patient has a positive Myriad HRD test, then I would not argue that they need to have a PARP inhibitor. So even though there may be other ways of determining, for example, better ways of determining whether they have active BRCA1 methylation, for example, but, you know, it's a long road to developing and validating a new HRD test. So the quickest way to finding out if a person has HRD positivity at the moment is to use a Myriad HRD test. I don't own any shares in Myriad, I can promise you that.
Thank you so much, Claire. I think that's all the questions we have. It was a fantastic talk. Thank you very much.
Thanks.
And it's my pleasure now to introduce Dr. Alan DeAndrea. Alan is currently the Fuller American Cancer Society Professor of Radiation Oncology at Harvard Medical School, and the director of the Center of DNA Damage and Repair, and the director of the Susan F. Smith Center for Women's Cancer at Dana-Farber Cancer Institute. I actually visited Alan's lab in 2018, and I found the research environment so inspiring. Learned so much, and Alan was so generous with his time and sharing of reagents. Alan is a fellow of the American Association for the Advancement of Science, a member of the National Academy of Medicine, and a member of the American Association for Cancer Research Academy. That was a recent appointment at the Academy, and it's a well-deserved recognition of his achievements. And the title of Alan's talk is a first-in-class polymerase theta inhibitor selectively targets homologous recombination deficient tumor. Over to Alan's talk.
And the title of my seminar is Polymerase Theta Inhibitor Overcomes PARP Inhibitor Resistance. I have the following financial relationships to disclose, but I will not be discussing any off-label use or investigational use of drugs in my presentation. So by way of introduction, many solid tumors are homologous recombination deficient. These include ovarian cancer, triple-negative breast cancer, pancreatic cancer, and prostate cancer. PARP inhibitors can kill these HR-deficient tumor cells, but HR-deficient tumor cells can become resistant to PARP inhibitors by many different mechanisms, and this often restores homologous recombination. PARP inhibitor resistance is a major problem in the clinic. After all, PARP inhibitors are oral drugs, relatively well tolerated, but once the tumor becomes resistant to PARP inhibitor, they no longer work. There's a major need for a drug which can overcome PARP inhibitor resistance, and targeting alternative DNA repair pathways may be one such mechanism for overcoming PARP inhibitor resistance. So by way of introduction, a DNA molecule can have a double-strand break, and double-strand breaks are normally repaired either by homologous recombination or non-homologous end joining. In the process of homologous recombination, this double-strand break is resected, leaving these 3' overhangs. And 3' overhangs could then invade a normal sister chromatid, the result being error-free homologous recombination repair. Alternatively, this double-strand break can be blunt-end ligated by the process of non-homologous end joining. And this is an error-prone repair mechanism. So in tumors like ovarian tumors, which are BRCA1 and BRCA2 deficient, or deficient in PALB2 or other HR genes, these tumor cells now require non-homologous end joining. There's an increase in non-homologous end joining repair of double-strand breaks, but the result is that these tumors become PARP inhibitor sensitive. However, the PARP actually restore homologous recombination, in some cases by somatically reverting the mutation in BRCA1 or BRCA2. And the end result is these tumors become resistant to PARP inhibitor. So how do PARP inhibitors kill HR deficient tumors? If a single strand break occurs in the DNA shown here, the single strand breaks are often corrected by the process of base excision repair, which is a PARP-dependent pathway. However, in the setting of a PARP inhibitor, this single strand break can be converted to double strand breaks, which then require HR for repair. Hence, the PARP inhibitor can kill BRCA deficient cells by the mechanism of synthetic lethality. Alternatively, a PARP inhibitor can bind to the PARP enzyme on the chromatin and create a trapped complex. And this trapped complex now requires homologous recombination for repair. Hence, the trapped complex will kill an HR deficient cell. Now, tumors can become resistant to a PARP inhibitor by many mechanisms, as I said, perhaps as many as 15 different mechanisms. The most commonly touted mechanism is somatic reversion. So if a tumor has a defect in homologous recombination, BRCA deficient, in the setting of a PARP inhibitor, there could be a somatic reversion or correction of the open reading frame, resulting in the generation of a functional protein, and these tumors then can become PARP inhibitor resistant. Alternatively, some tumors actually have a BRCA1 hypermethylation. These tumors are sensitive to a PARP inhibitor, but in the setting of a PARP inhibitor exposure, these tumors now can express BRCA1 protein, and now they can become resistant to a PARP inhibitor. Now, alternatively, in some tumors which have hypomorphic mutations in BRCA1 or BRCA2, these encode mutant proteins with partial activity. But in the presence of a PARP inhibitor, these tumors might upregulate the expression of the mutant protein to the level at which the cells become resistant to a PARP inhibitor. This is a well-known mechanism. Another mechanism by which a tumor can become resistant to a PARP inhibitor is by upregulating this kinase pathway, the so-called ATR CHEK1-WEE1 pathway. So in the presence of a PARP inhibitor, these tumor cells might have an increased expression of single-strand DNA, which activates the ATR CHEK1-WEE1 pathway. This pathway now can stabilize a replication fork, and the cells become resistant to a PARP inhibitor. So accordingly, if one had a small molecule inhibitor of ATR or CHEK1 or WEE1, one might block this pathway and resensitize the cancer cell to a PARP inhibitor. And there's a lot of interest in clinical trials now to develop small molecule inhibitors of ATR, CHEK1, or WEE1, which will make a cell more sensitive to a PARP inhibitor. So the mechanism I'd like to describe to you today, though, is small molecule inhibitors of alternative end joining. So as I said at the beginning, a double strand break, at least during the S phase of the cell cycle, can undergo a resection, leaving these 3' overhangs. Normally in S phase, these 3' overhangs lead to homologous recombination repair, an error-free repair pathway. But in BRCA1 and BRCA2 deficient cells, this HR pathway does not work. And now the cells switch over to an alternative end joining pathway, which is a very functional pathway during the S phase of normal cells. This alternative end joining pathway requires an enzyme called polymerase Q, or polymerase theta. It also requires the PARP enzyme. And these cells now, in the presence of an alternative end joining pathway, can undergo microhomology mediated repair, which, as I said, is a very adaptable mechanism of DNA repair. It's error prone, and these tumor cells, which are HR deficient, now using alternative end joining, can now generate repair, but also generate a mutational signature called cosmic signature 3, which is generated by the polymerase Q enzyme. So we showed some years ago now that there's a synthetic lethal relationship between homologous recombination and polymerase theta-mediated alternative end joining. And the way we did this was sort of by a classic approach of mouse genetics. We had a mouse knockout of polymerase theta, and this mouse actually had a very mild phenotype. It had an alternative end joining deficiency. In fact, the only phenotype of these mice was these mice had increased micronuclei observed in the red blood cells, the peripheral blood. We crossed these mice with a mouse which had a mild defect in homologous recombination. This was a mouse which is defective in homologous recombination because of a mutation in the Fanconi gene. These mice also, as I said, had a very mild phenotype. But when we crossed these mice, we never developed viable offspring. So essentially what we showed was that knocking out an HR pathway and knocking out alternative end joining resulted in embryonic lethality. This embryonic lethality, or synthetic, was confirmed in as CRISPR screen. So this was a CRISPR screen that we performed with Steve Elledge's laboratory a couple of years ago. And what we showed was that BRCA2 deficient tumor cells, when exposed to a whole genome CRISPR screen, these cells could not thrive at all if the cells took up a guide RNA directed against polymerase Q or directed against another microhomology-mediated adjoining gene, namely the FEN1 gene. So this further confirmed that knocking out microhomology-mediated repair, knocking out POLQ, is synthetic lethal with an HR gene, in this case BRCA2. So for all these reasons, we thought it might be a good idea to try to screen or develop small molecule inhibitors of polymerase Q, thinking that these small molecule inhibitors would kill an HR deficient tumor cell, much the way a PARP inhibitor would kill an HR deficient tumor. So polymerase Q is a big enzyme. Turns out it's over 2,500 amino acids.
$1,000, I should say. It's a very big enzyme. And it has two enzymatic domains. It has a polymerase domain at the C-terminus, and it has an
ATPase domain, or a so-called helicase domain at the amino terminus. Now, we knew what the different functions were of these different enzymatic domains. For instance, the polymerase domain actually performs the function of microhomology-mediated end joining. The helicase domain, or the ATPase domain, is required for targeting this protein to sites of DNA damage. It's also required for stripping off RAD51 from sites of abortive homologous recombination repair. So we decided to screen for small molecules that target the amino terminus of this enzyme. And in so doing, we found a first-in-class polymerase theta inhibitor, which selectively targets cells for homologous recombination. And this paper is now in press in the journal Nature Cancer. So to do this, we generated the amino terminal half of the polymerase Q enzyme. This amino terminal half encodes a very robust ATPase activity. So here's the 1,000 amino acid amino terminal half of polymerase Q. We did a small molecule screen, and after screening for thousands of small molecules, we actually found a small molecule, a known small molecule called novobiacin, which is a known ATPase inhibitor, which very effectively inhibited the ATPase of polymerase Q. So what is novobiocin? So it turns out novobiocin, here's the structure shown here, is a known antibiotic. It's an antibiotic that's been used for many years to treat E. coli bacterial infections. In fact, novobiocin is known to target quite specifically an enzyme called DNA gyrase, which is an ATPase of gram-negative E. coli. It turns out that this small molecule novobiocin also inhibits the ATPase of polymerase Q. In fact, at a relatively low IC50 of 24 micromolar. And this 24 micromolar is actually a concentration that's readily achievable in humans treated with novobiocin. So in details that I won't get into in my talk, we know now that novobiocin can actually bind quite specifically to the ATPase of POLQ. The novobiocin, when it binds to the ATPase of POLQ, can actually thermally shift and stabilize the polymerase Q enzyme. The novobiocin can actually kill BRCA1 and BRCA2 deficient tumor cells in vitro, consistent with its ability to block polymerase Q. And interestingly, polymerase Q deficient cells are actually quite resistant to novobiocin. So to go through a little bit of this data, what we initially did was we generated a green fluorescent tagged, a GFP tagged polymerase Q enzyme. When we drove a laser through normal human cells, you actually found that this GFP tagged polymerase Q targeted quite well to the sites of the DNA damage. However, if you pre-treated or concurrently treated the cells with novobiocin, the drug, this drug now blocked the recruitment of the DNA repair enzyme POLQ to the sites of DNA damage. If one mutated the ATPase domain with a point mutation in the ATPase domain, this mutant protein failed to recruit to sites of DNA damage. However, if one mutated the polymerase domain of POLQ, this mutant protein still quite effectively recruited to sites of DNA damage. So for these reasons, we were able to demonstrate that the ATPase activity of polymerase Q is required for its recruitment to sites of DNA damage, and that novobiocin blocked this recruitment. We also found that the novobiocin compound, as shown here, when we coupled it to beads covalently, shown here is the yellow beads, that the yellow novobiocin beads actually could pull down polymerase Q ATPase, but could not pull down a lot of other DNA repair enzymes that had ATPase activity. And finally, what we did was we purified a lot of ATPase containing DNA repair enzymes, including SMARCA, TRP13, Bloom helicase, CHD1, RAD51, etc. And we found that when we looked at these purified ATPase containing enzymes, we found that novobiocin only inhibited the ATPase act of the polymerase Q itself, but it did not seem to inhibit the ATPase activity of these other related enzymes. And this really allowed us to conclude that novobiocin very specifically inhibits the ATPase of POLQ. To look at this more closely, we collaborated with John Tainer and Alib Saeed, well-known DNA repair structural biologists. And we actually found that the novobiocin compound can actually rather selectively bind to a tunnel, a deep tunnel, which is found on the ATPase of polymerase Q. And this tunnel is not observed in the crystal structure of other related ATPases. And when novobiocin binds to this deep tunnel on polymerase Q, it actually non-specifically and non-competitively, should say, competes with the binding of ATP. So it turns out novobiocin is a non-competitive inhibitor of the polymerase Q ATPase domain. So naturally, we wanted to go directly to in vivo studies because we knew that polymerase Q was a safe drug, or sorry, that novobiocin was a safe drug, and it could be, we can achieve serum concentrations in treated cancer patients with this drug. We wanted to test for its ability to kill BRCA deficient cells. So the first tumors we looked at were triple-negative breast cancer cells. I'll also show you ovarian cancer cells in a moment. So what we did here, using conquers. This is a BRCA1 deficient genetically engineered mouse model of triple negative breast cancer. So what these mice do is these mice develop a mammary tumor over a period of 140 to 280 days. And this triple negative breast cancer grows at a relatively indolent level. But when this tumor chunks are inserted into the mammary gland of a colony of mice, we end up generating a colony of mice which have this very aggressive triple negative breast cancer, which is BRCA1 deficient. And interestingly, when we treat these mice now with either sham treated or untreated mice, the tumor grows very rapidly and the mice die very quickly. However, if one treats these mice with novobiocin, one finds that these mice actually are saved and the BRCA1 deficient tumor cell rapidly regresses. And one sees a very rapid regression of these BRCA1 deficient tumor cells, similar to the regression that we see if we treated these mice with a PARP inhibitor. So it turns out that novobiocin, the Pol theta inhibitor, is quite synergistic with PARP inhibitor. So for instance, in this case, we took a BRCA1 deficient cell line, and we show that this BRCA1 deficient cell line is quite sensitive to a PARP inhibitor, and even in concentrations of as low as 10 nanomolar IC50 of PARP inhibitor. But if one adds novobiocin, in this case 100 micromolar concentration of novobiocin to the PARP inhibitor, one sees impressive synergy, shown here on the bottom left with this leftward shift, that treating these tumor cells with Recombination, a PARP inhibitor with novobiocin, one sees a very pronounced killing using this drug combination. And shown here at the bottom right, you can see that the Recombination, the PARP inhibitor, actually kills these BRCA1 deficient cells at about a 1 to 2 nanomolar IC50. But if one adds novobiocin, one could drop this 20-fold. And now the novobiocin co-treatment reduces the IC50 of the PARP inhibitor to as little as 0.1 nanomolar IC50. So we next turn to a set of ovarian cancer patient-derived xenograft models, PDX models, that we have in our laboratory. So you can see here, there are 14 such models. One model, this is a patient-derived xenograft called DF83. These ovarian tumors are very deficient in homologous recombination. Are very deficient in homologous recombination repair. Versus, say, some of these other BRCA1 deficient PDX models, which have acquired PARP inhibitor resistance. So here's one such model, DF59, which is BRCA1 deficient, but it has RAD51 foci, consistent with the fact that this BRCA1 deficient tumor model has acquired homologous recombination and has acquired PARP inhibitor resistance by inactivating the gene 53BP1. And what you can see here, that the DF83 model, which is very BRCA deficient, these tumor cells now are quite sensitive to a PARP inhibitor, okay? They're even more sensitive in vivo to the novobiocin. And if one uses a combination of novobiocin, the Pol theta inhibitor, with a PARP inhibitor, there are essentially no tumor cells which survive in these mice. The mice do very well. And this combination of drug kills the tumor quite effectively. But the even more interesting case is on the right here. This is a BRCA1 deficient PDX model. Okay, and this BRCA1 deficient PDX model is very resistant to a PARP inhibitor in vivo, but it is still sensitive to the novobiocin Pol theta inhibitor, and it's extremely sensitive to the combination of the PARP inhibitor Olaparib with novobiocin. And for this reason, we believe that a combination of a PARP inhibitor with a Pol theta inhibitor will be a very effective way to treat in vivo, certainly this mouse model and perhaps humans, with BRCA deficient but PARP inhibitor resistant tumors. We've developed a nice pharmacodynamic worker, because it turns out if you treat these cells now, which are PARP inhibitor resistant, and BRCA1 deficient, if you treat these cells with novabiocin, you activate the production of RAD51 foci, which are readily detectable by immunohistochemistry. And when one treats these tumors in vivo with a combination of Pol theta inhibitor novabiocin with Olaparib, one sees this vast increase in RAD51 foci formation. So this is a pharmacodynamic biomarker which we're using in our human clinical trial. The other thing is we found an impressive predictive biomarker. That is to say, any tumor cells which have elevated levels of polymerase theta or POLQ expression seem to be more sensitive to polymerase to the Pol theta inhibitor novabiocin. But any tumors which actually have resistance to novabiocin actually have decreased expression of POLQ messenger RNA and POLQ protein by immunohistochemistry. So we now would like to look at this combination of polymerase theta inhibitor and PARP inhibitor in other models. So here's one such model. This is a model of a BRCA2 deficient pancreatic cancer. In this BRCA2 deficient pancreatic cancer, known as CAPAN1, is quite resistant to a PARP inhibitor. The BRCA2 deficient cells are very sensitive to the PARP inhibitor Olaparib, very sensitive to the Pol theta inhibitor. But we've actually found and screened for resistant versions of these BRCA2 deficient cells, which have a somatic reversion in BRCA2. And the BRCA2 cells which have been somatically reverted, these somatic reversions are now quite resistant to a PARP inhibitor. And in this case, they're also resistant to the Pol theta inhibitor. And when the cells become resistant to the Pol theta inhibitor, they now lose expression of the polymerase theta gene and protein product. So with these observations in mind, we'd like to examine more human systems of PARP inhibitor resistance. So what our laboratory has been doing in the last few years is generating ovarian cancer organoid models. And we did this in collaboration with Sarah Hill and some pathologists at the Dana-Farber Cancer Institute. What we do is we actually get biopsies of ovarian cancers directly from our gynecologic surgeons at the Brigham and Women's Hospital. We get these ovarian cancer biopsies taken right from the operating room. We bring them to the laboratory and we mince these ovarian tumors into single cell suspensions, and we put these single cell suspensions into organoid cultures. Organoid cultures, essentially, this is matrigel, which is combined with a cocktail of a number of growth factors which allow these ovarian tumors to grow out as organoids. So you can see here, for instance, these organoids, these human ovarian cancer organoids, can be tested for drug sensitivity. In this case, for instance, CHEK1 inhibitor sensitivity or ATR inhibitor sensitivity or PARP inhibitor sensitivity. We can do functional assays on these primary organoid cultures right from the tumors. We'd look, for instance, at RAD51 foci, which is a measure of competent homologous recombination repair. Alternatively, we can take these organoid cultures and look at their replication fork stability. For instance, we have found that those organoid cultures which have a defective replication fork are actually quite sensitive to CHEK1 inhibitors and ATR inhibitors in vitro. Or, of course, we can do DNA sequencing on these organoids and look for genetic abnormalities which might suggest PARP inhibitor sensitivity or polymerase theta inhibitor sensitivity. What we found is that these organoids are actually very good replicas of the human tumor. So, for instance, this woman had this ovarian cancer, which was p53 mutant and Pax8 positive. When we generate the organoids directly from these tumors, these organoids grow out very quickly in a period of 7 to 10 days. You can see that these organoid cultures still have lymphocytes, and immune and dendritic cells. So in fact, these organoid cultures are useful ways of studying checkpoint blockade antibodies in addition to cytotoxic drugs. If one actually examines the genetic profile of the organoids versus the tumor from which they're derived, we actually find a very high concordance. The same mutations that we find in the organoid culture are generally found in the tumor from which they're derived. Again, because these organoids grow out so quickly from the tumor, we feel that they're a very good surrogate model of the tumor itself for doing drug testing. We can also do functional tests. So for instance, this was a organoid culture that was generated from a primary human tumor, which had a RAD51 deficiency, which had a PARP, a BRCA deficiency, and these tumors had no RAD51 foci, and accordingly, these organoid cultures were very sensitive to a PARP inhibitor, Olaparib. This on the right, this was another patient, a tumor derived from a patient that had a BRCA germline mutation. Okay, but despite that BRCA germline mutation, these organoids were very resistant to a PARP inhibitor, Olaparib, and accordingly, these organoids had RAD51 foci. So by doing these functional tests, we could quickly functionally determine whether or not the tumor was going to respond to a PARP inhibitor or not respond. And we could give this clinical information back to the medical oncologist taking care of the patient. For instance, this patient, organoid cultures were clearly resistant to the PARP inhibitor. And when we went back to Ursula Matulonis, who's caring for this patient in the clinic, it corresponded to the fact that this patient's tumor was not responding to a PARP inhibitor in vivo. Here's another, so we have a sort of this general theme then. When we take a tumor from a woman who has an ovarian cancer, we can do genetic sequencing of that ovarian tumor and get a sense of what the DNA repair profile is of that tumor. But at the same time, we can generate functional organoids from that patient and do functional testing and drug screens. So here's an example then of the novabiocin example, which I just showed you. So here was a patient who the tumor actually, the organoid culture was actually very sensitive to the polymerase theta inhibitor novabiocin. In this case, the tumor organoid was also very sensitive to a PARP inhibitor. And when we use the combination of the polymerase theta inhibitor novabiocin with the PARP inhibitor for this patient's organoids, we actually found that the combination was very effective in killing these cells. This was another patient whose organoid culture had minimal sensitivity to the Pol theta inhibitor novabiocin, was completely PARP inhibitor resistant. When we looked at the combination of the Pol theta inhibitor with the PARP inhibitor on these organoids, we found that the combination again was very effective in treating this patient's tumor cells in vitro. So we believe this kind of combination testing of a Pol theta inhibitor with a PARP inhibitor on organoids in vitro might be a very rapid way of determining whether or not a tumor will respond in vivo. And now we're trying to correlate the sensitivity of the organoid culture to these drug combinations with the sensitivity of the drugs of the patient treated in the clinic. So in summary of what I said then is the following. I said at the very beginning that HR deficient tumor cells are PARP inhibitor sensitive, that they can acquire PARP inhibitor resistance by multiple mechanisms, often by restoring homologous recombination repair. That HR deficient tumor cells are sensitive to either a PARP inhibitor or a Pol theta inhibitor, novabiocin. But the tumors with acquired PARP inhibitor resistance can actually remain sensitive to a Pol theta inhibitor. And this is the most important point of my talk. That novabiocin, a polymerase theta inhibitor, can actually kill PARP inhibitor resistant cells by causing increased double-strand break end resection and by activating this pharmacodynamic biomarker, toxic RAD51. And finally, on the basis of this work, in collaboration with Jeffrey Shapiro, a well-known phase 1 trialist who I work with at Dana-Farber, we're now conducting a clinical trial using a combination of the polymerase theta inhibitor, Pol theta inhibitor novobiacin, with the PARP inhibitor for patients who have acquired PARP inhibitor resistance. And we've initiated this clinical trial under the auspices of our National Cancer Institute Experimental Therapeutics Program, a so-called NEXT program. And patients will be enrolling in this clinical trial later in 2021. So by way of acknowledgements, I'd like to very much point out a very talented postdoctoral fellow in our laboratory, Jia Zhu, who found and screened for novobiacin as a polymerase theta inhibitor. This work is done in collaboration with Raphael Sicaldi, the Sicaldi Laboratory at the Institut Curie in Paris. I referred to some structural work that was done in collaboration with John Tainer and Alib Saeed, showing how novobiacin can actually bind directly to the polymerase theta target. And perhaps most importantly, we're now conducting this clinical trial in collaboration with Jeff Shapiro using a combination of the Pol theta inhibitor, novobiacin, with PARP inhibitor for the treatment of these PARP inhibitor resistant tumors. So I will stop there and happy to answer questions.
Thank you very much, Alan. So Alan's talk was recorded, and I believe he's with us live for question and answers. Hi, Alan. It's evening time in Boston. Thank you for joining us.
Thank you for having me. It's really wonderful. I recorded my talk because I wasn't sure how good my computer would work, but in fact, I could have given it live, but I did not. But happy to answer some questions. Now, I'd like to say thanks so much for the invitation to talk. I learned so much, from Kathleen's talk and from Claire's talk and from the questions. So it's really a great opportunity. Thank you.
Thank you. So a question from Claire. Great talk, Alan. How exactly is RAD51 accumulation toxic? Thank you.
Yeah, that's a good question. I think the RAD50, if HR is not working, if homologous recombination is not working at a double strand break, it has to be stripped off in order for microhomology mediated repair to work. So we're Pol theta to come in and perform microhomology mediated repair. It has to get the RAD51 out of the way. So if you inhibit that step, it clogs the system. So actually, I think this buildup of RAD51 is useful because it's a sign that the drug is hitting the tumor. So it's a useful pharmacodynamic marker. And it's been described in other systems, RAD51 toxicity, it's called.
So I have a few questions. So you mentioned earlier in your talk that signature 3 is a predictor of Pol theta activity. So can that be a biomarker to be used in the clinic to predict response?
Yeah, I mean, I think, obviously, very good question. Signature 3 is certainly being used as a marker for an HRD deficient. But actually, the data from several labs is now showing that signature 3 is actually caused by the polymerase theta enzyme, with the error-prone polymerase 3 enzyme. So I think so the signature 3 is a sign of HRD, a sign that there is now or has been a homologous recombination deficiency. But it's also a sign that polymerase theta activity is upregulated, and therefore Pol theta inhibitor might be useful. So I think it's a useful biomarker. So HRD essentially is a biomarker for
Pol theta.
PARP inhibitor and for Pol theta.
Yeah. And we have a question from David Bautel. Hi, Alan, great talk. I'm sorry if I missed this during the talk, but is NVB killing cells or is it cytostatic? Separate any ideas about NVB resistance?
Yeah, no, I think it might be the NVB, which is novobiacin. I think it might be cytostatic, but when it's combined with the PARP inhibitor, I think there's enhanced cytotoxicity. And actually, Kathleen referred to this really nicely during her talk. She pointed out that the Pol theta inhibitor novobiacin, it kills HR deficient cells, but it also prevents, by blocking Pol theta, it actually prevents mutations and prevents somatic reversion of the BRCA gene. So if one used novobiacin up front with a PARP inhibitor, you might have a better kill of the tumor, but you might also prevent the mutational events that lead to PARP inhibitor resistance. So that's a pipe dream, but actually it's a very sensible one.
So do you think it can also overcome replication fork stability, that phenotype associated with resistance to PARPi as well?
That's a good question too. Yeah, so it looks like we do know that polymerase theta is recruited to replication forks. Most of what we know now about polymerase theta is it works at double strand breaks, but it is also recruited to replication forks. So it's possible that the Pol theta inhibitor will further disrupt a replication fork and kill a BRCA2 deficient cell that has an unstable replication fork. So I think that, you know, a little bit of this is hand waving, but there's a lot of labs now working on polymerase theta. It definitely has a function at double strand breaks, but it definitely has a function in replication forks as well.
Yeah.
Yeah.
So the second part of David's question was about resistance to novobiacin. Resistance to novobiacin. So do you think, I think in the CAPAN1 cell line data, you saw loss of expression of Pol1 theta?
Mm-hmm.
So do you think that can be a potential mechanism of resistance?
Yeah, that possibly could be. That loss of expression of the target might actually result in resistance. So in other words, maybe novobiacin is binding to Pol theta and trapping it. And if you lose the Pol theta, you lose the target, the cells become resistant. So that is one possible mechanism. We're interested in finding mechanisms of novobiacin resistance. Now, you know that Anina Farkila, when she's in our laboratory, found multiple mechanisms of PARP inhibitor resistance. Now we'd like to select cells in vitro that become novobiacin resistant and then try to understand what's the mechanism of the acquired resistance. So just as you asked.
Yeah. And are you interested in combination of chemotherapy, or you think that's not really the way to go?
Well, I mean, I think with I do think the combinations are inevitably going to be needed. Obviously, we're interested in the combination of novobiacin with a PARP inhibitor, but there's some evidence that novobiacin also activates micronuclei. And in fact, that was the only phenotype in the Pol theta knockout mouse was micronuclei. So it's quite possible that Pol theta inhibitor will synergize with checkpoint blockade with a PD-1 antibody, and that's something we're looking at. So yeah, combinations are very much on the docket.
Yeah. Hope to see very good results in the clinic. That's what we look forward to. Yeah,
that would be nice. Yeah.
There are no further questions. Thank you so much, Alan, and we hope to see you in Australia one day.
Yes, I'd like to return. I love it there.
Yeah.
Okay. All right. Good. Thanks very much.
Thank you so much. So I would like to thank all speakers today for a great session. And also, this is the last session of the symposium. It's been a wonderful symposium, and I would like to thank all the speakers who have presented and everybody who has attended over the past 2 weeks. And just as a reminder that when you quit the event, you'll be redirected to a survey. The organizing committee would like to ask you to participate in the survey so we can improve future meetings. And thank you so much for your attention. Goodbye.